Hello, my name is Catriona Steele, and it's my pleasure to present this webinar at the invitation of Nestle Health Science. First, just a brief introduction about me as the speaker. I am a clinical researcher, and I direct the Swallowing Rehabilitation Research Laboratory at the KITE Research Institute of the Toronto Rehabilitation Institute University Health Network. My clinical training is as a speech-language pathologist, and I am a professor in the Department of Speech-Language Pathology at the University of Toronto. I currently hold grant funding from the National Institute of Deafness and Other Communication Disorders in the United States. And over the past 10 years, I have held several research contracts with Nestle Health Science, some of which have led to the research that I will be sharing today. Finally, I am active in several volunteer roles. I serve as a board member of IDSE, the International Dysphagia Diet Standardization Initiative, and also of DRS, the Dysphagia Research Society, and I am an associate editor for the Dysphagia Journal. Nestle has asked me to talk to you about residue as a problem we might see in patients with dysphagia. My plan for the next 20 minutes or so is to try to address several key questions about residue. First of all, what is residue? How do we define it? And what is not residue? Second, what do we understand about the physiological mechanisms that lead to residue? Third, what are the different ways that you as a clinician can measure residue and understand its severity? Fourth, are there specific conditions where we should expect to see residue, for example, with thickened liquids or with barium? Fifth, when should we be concerned about residue? That is, how much residue is too much, such that it represents a risk for aspiration after the swallow? And finally, what do we know about effective ways to reduce residue? So let's start with a question of definition. What is pharyngeal residue? Residue is bolus material that is left behind in the pharynx after a swallow. The most common locations for pharyngeal residue are the valleculi at the base of the tongue in front of the epiglottis, and in the piriform sinuses, which lie on either side of the hypopharynx behind the larynx. And just to be clear, when I use the term pharyngeal residue, I'm distinguishing this phenomenon from oral residue left behind in the mouth after a swallow, and also from pooled salivary secretions that may be in the valleculi and the piriform sinuses before a swallow, or material that enters and collects in these spaces before the swallow, which some people call pooling or premature spillage. I'm also distinguishing pharyngeal residue from material that remains behind in the laryngeal vestibule after a penetration aspiration event. One question that we probably need to get out of the way right at the beginning is whether it is ever normal to have residue. You might be thinking, are there foods or liquids that always leave residue or a coating, even in healthy people? Perhaps things like a creamy salad dressing or dairy products. And the answer, as far as we know from research, is no. Healthy people generally swallow a bolus in a single swallow with no residue left behind. I will talk more about this a little later in the webinar. So if residue is not normal, how does it happen? Residue is a sign of impaired swallowing efficiency. And here we mean that there is a problem in the physiological events that propel the bolus through the pharynx and into the esophagus. Previous papers have suggested that we could take a closer look at 4 elements that are involved in successful bolus propulsion and clearance. First, work by Jackie Hind and colleagues suggests that boluses that are particularly thick or sticky are more likely to leave residue behind. Second, several studies point to tongue weakness as something that may contribute to poor bolus propulsion and residue. And importantly, these studies also suggest that improved residue may be an outcome of tongue strength training. Third, the literature suggests that there is a strong association between poor pharyngeal constriction behind the bolus and residue. And finally, if there are problems either with the diameter or the duration of upper esophageal sphincter opening, then residue may be left behind in the pharynx. Of these possible predictors, by far the strongest association in the research literature has been seen between poor pharyngeal constriction and residue. For example, these graphs from a paper by Dr. Ashley Waito and colleagues show strong correlations between poor pharyngeal constriction, meaning a larger unobliterated area of the pharynx at the point of maximum constriction, and residue in the vallecula and the piriform sinuses in patients with ALS. Interestingly, the strongest correlations here were seen with the largest bolus size. Now, these graphs both plot residue on the y-axis according to a scale known as the normalized residue ratio scale. And this leads us to the next question, which is about different approaches to measuring residue severity. The simplest approach to measuring residue is to make a visuoperceptual judgment of its location and severity. There are several examples of this type of approach in the literature, starting with simple binary notations of residue presence or absence, moving to 3-level scales, such as the one used by Dr. Joanne Robbins, to 4-level scales that follow a none, mild, moderate, severe continuum, to scales that capture the number of different locations where residue is seen in the pharynx, such as the bolus residue scale developed by Dr. Natalie Rommel. Although visuoperceptual judgments may seem simple, they do have several limitations. First of all, they lack precision, and it is difficult to calibrate judgments across clinicians, particularly when residue may be hovering around a boundary between two categories, such as mild and moderate. Many of these scales rely on estimation, either of the percent of the bolus that is left behind, or of how full a space in the pharynx might be. And probably most seriously, these judgments may not be sensitive to clinically meaningful change. Consider, for example, the 3-level scale used by Dr. Joanne Robbins, which has levels of none, a light coding, and more than a light coding. Let's illustrate with the analogy of a glass filled with liquid. This glass represents a patient who has a lot of residue at the beginning of treatment. And after several weeks of treatment, suppose that the residue has dropped to about half of the amount seen at baseline. This could be highly significant from a clinical perspective, but on a scale of none, a little, or more than a little, you would have to choose more than a little. In order for the scale to reflect improvement, the patient would need to have a more substantial reduction in residue so that you could call it a little. In terms of precision, some visuoperceptual scales attach numbers to the grades of severity. One example is the Eisenhuber scale, which uses 25% increments of how full a space is of residue. However, recent research from our lab shows that when these estimates are compared to actual pixel-based measures, even with highly trained and calibrated raters, judgments of mild residue were underestimates 16% of the time. Judgments of moderate residue included both under and overestimation. And judgments of severe residue were overestimates 21% of the time. So, if you want to measure residue precisely, this can be done using pixel tracing tools, which is something like using Photoshop to edit a photograph. There are several software tools available for doing this. In my lab, we use a freeware called ImageJ. Once you have a suitable software, you can trace residue on a frame at the end of a swallow and then determine the ratio of that residue area to a scalar. In our lab, we use the squared length of the C2 to C4 vertebral spine as that scalar, and residue is expressed as a percentage of that area. In this example, the yellow outlined residue in the vallecula takes up 2.7% of the C24 squared reference area, which is shown by the white dashed square. The piriform sinus residue, which is outlined in turquoise, takes up 1.9% of that reference area. As a note, the normalized residue ratio scale, or NRRS, must be reported separately for the vallecula and the piriform sinuses, but the other 3 measures listed on this slide allow for residue in different areas to be added together to produce a total pharyngeal residue measure. So now that we have covered different approaches to measuring residue, You might be wondering what we know about normal amounts of residue in healthy adults, and whether certain liquids should be expected to leave worse residue than others. Let's break this down into 3 important sub-questions. First, how much residue is normal in healthy individuals on thin liquids? Second, should we expect more residue with thicker liquids? And third, does barium leave residue behind? Regarding the first 2 questions, last year my lab published new reference values for video fluoroscopic measures of swallowing in healthy adults aged under 60. The publication provides reference values for thin, slightly thick, mildly thick, moderately thick, and extremely thick liquids that were all prepared with Nestlé's Thicken Up Clear xanthan gum thickener. We also tested liquids prepared with Nestlé's Thicken Up starch-based thickener, but those are not yet published. On thin liquids, we found that healthy people typically have residue measuring 1% or less of the C24 squared reference area after taking a naturally sized sip from a cup. When we looked at slightly thick and mildly thick liquids, which were also taken as natural sips from a cup, we found greater residue on the mildly thick liquids, typically measuring up to 2% of the C24 squared reference area. And on moderately thick and extremely thick liquids, which were taken in smaller volumes by teaspoon, we found that residue typically fell back down below that 1% C24 squared value, except with the starch-thickened moderately thick liquids. To summarize our findings, we found only small increases in residue as liquids became thicker. And because those moderately and extremely thick liquids are too thick to sip from a cup and were served with a spoon, this generally mitigated the concern about greater residue based on the smaller sip volumes. The other take-home message from these data is that if your patient needs moderately or extremely thick liquids to improve their swallowing safety, these data would suggest that a gum thickener is less likely to leave residue than a starch-based thickener. So we've covered what to expect in healthy adults in terms of residue on thin and thickened liquids, but what about barium? It is important to know that some barium products are actually intended to leave a coating on the mucosal walls of the gastrointestinal tract. Here it's important to pay attention to the concentration of the barium that you are using. Suspensions with a higher concentration of barium, meaning 100% weight to volume or more more likely to leave a coating behind. Low concentration bariums, meaning bariums in the range of 20 to 40% weight to volume, are specifically designed not to leave any material behind. Let's watch 3 short video fluoroscopy clips to illustrate this issue. These recordings are all taken from the same healthy young woman. First on the left, she is swallowing a 100% weight to volume liquid barium suspension called Polybar. At the end of the swallow, you can see small amounts of coating on the tongue base, around the epiglottis, and also in the cervical esophagus. The important question here is whether you might have called this trace residue if you saw it in a patient and didn't know that this recording was from a healthy person. In the middle example, the same person is swallowing a less concentrated 60% weight to volume product called liquid EasyPake. Here the pharynx is cleaner at the end of the swallow, and I think it's unlikely that a clinician would comment on any residue being present. Finally, on the right, she is swallowing that same liquid EasyPake product, but it has been diluted to a 20% weight to volume concentration with water. Here the pharynx is completely clean at the end of the swallow. So the take-home message here is that you should find out whether the barium that you are using is supposed to leave a coating or not. And ideally you should use lower concentrations to avoid confusing expected coating for residue. So we've discussed evidence showing that residue generally falls below 1% of the C24 squared reference area in healthy adults. But what happens when we see more residue than that in patients? Specifically, when there is residue above this level, is there a risk that it will be aspirated? Our lab recently had an opportunity to look at this question by examining data that were collected in a study funded by Nestlé called the SONAR study. This was a large study collected across 7 hospitals in the United States, and participants included 332 adults referred for video fluoroscopy due to non-congenital, non-surgical, non-cancer risk for dysphagia. If you're interested in the main study, you can read more about it at the link shown on the slide. The participants in this study each swallowed 15 boluses of different consistencies, and this gave us a huge data set of more than 4,400 swallows to analyze to understand the link between residue and penetration aspiration. What we did was to start by measuring how much residue we could already see present in the pharynx at the beginning of each swallow. And by doing this, we were able to divide the whole data set up into 3 different types of swallow. Those that had a clean baseline, meaning that there was no material in the pharynx before the swallow. Second, clearing swallows of residue where no new bolus was swallowed. And third, swallows of new material that happened in the situation where there was already pre-existing residue in the pharynx. If residue was present, we measured it so that we could determine if it was greater or less than that 1% C24 squared reference value. And we looked at whether the rates of penetration and aspiration were different depending on the type of swallow and the amount of residue present. This slide shows you the percentage of the clearing swallows and the swallows of additional material where the residue that was already present in the pharynx was greater than 1% of the C24 squared reference area. You can see that this was the case for 91% of those clearing swallows and 71% of the swallows of additional material. To understand the impact of this pre-swallow residue on the risk of penetration and aspiration, let's begin by noting that the frequencies of penetration aspiration scale scores of 3 or worse on the clean baseline swallows in this data set were 5% for thin and mildly thick liquids and 1% for the moderately and extremely thick liquids. By comparison, 20% of the thin and 11% of the mildly thick clearing swallows showed penetration aspiration, meaning that penetration aspiration was at least twice as likely on these clearing swallows. Interestingly, there were no examples in the dataset of clearing swallows with penetration or aspiration for moderately or extremely thick liquids. This is consistent with the general evidence suggesting that thickened liquids are less likely to be aspirated, but it may also suggest that when residue is really thick, it doesn't move very easily. When we compare the rates of penetration aspiration between the clean baseline swallows and the swallows of additional material where pre-swallow residue was already present above the 1% threshold, we saw 1.86 to 3.72 times the odds of penetration aspiration depending on consistency. So in terms of how much residue is too much, our conclusion is that when there is residue in the pharynx above the 1% C24 squared reference amount, that is the upper limit for residue in healthy people, this represents at least double the risk for penetration aspiration on subsequent swallows, regardless of whether they are clearing swallows or swallows in which a new bolus is swallowed on top of pre-existing residue. So we've now discussed the definition of residue, the mechanisms behind residue, different approaches to measurement, whether residue is more severe with specific liquids, and the risk of penetration and aspiration associated with residue above the levels typically seen in healthy swallowing. And the final question for our consideration today is what we as clinicians can do about residue. There are very few research studies that have directly looked at residue as an outcome of dysphagia treatment. And unfortunately, much of the available evidence has used scales that are not very sensitive to change. So let's approach this clinically, and I'll mention research where it is available. Earlier, we highlighted extremely thick or sticky boluses, weak tongue propulsion, poor pharyngeal constriction, and issues with UES opening as mechanisms contributing to pharyngeal residue. With respect to the bolus, as clinicians, we should consider whether our patients are having greater difficulty with extremely thick or sticky boluses. And here I will just briefly remind you that you can measure the properties of a liquid using ITSE's testing methods. The concern here is about liquids in that extremely thick range, or level 4 on the ITSE framework. These liquids are too thick to flow through a syringe in the ITSE flow test, so their properties should be tested instead using the ITSE fork drip test and the ITSE spoon tilt test. The spoon tilt test is specifically intended to identify whether a bolus is sticky. If an extremely thick liquid does not slide easily off a tilted spoon in a cohesive bolus, or if it leaves a thick coating behind on the spoon, then it is likely to be challenging for a person with dysphagia to swallow and is likely to be a risk for residue. Next, we can consider interventions for reduced tongue strength. Here, several studies point to improved bolus clearance and reduced residue being outcomes that you can expect from a course of lingual resistance training. I've published a couple of these studies myself, including the article shown on the slide, where we compared 2 different tongue pressure training protocols in people with dysphagia following stroke. And patients in both treatment arms showed significant improvements in molecular residue. Dr. Nicole Rogospoulia is currently leading a large pragmatic trial of lingual resistance training across several VA hospitals in the United States, where residue is the primary outcome. So we look forward to hearing the results of that study. In terms of treatment targeting poor pharyngeal constriction and short or inadequate UES opening, there is very little evidence in the field at the moment, and these are areas for future study using both manometric measures of pharyngeal pressure and measures of residue as outcomes. For now, however, there are several interventions that are thought to improve bolus clearance and UES opening. These include the effortful swallow, the Mendelssohn maneuver, and the Shaker head lifting exercise, along with variations on that approach, such as chin tuck against resistance and the recline exercise. One caution about the available evidence to date is that it is heavily dominated by studies that look at exercise effects in healthy adults rather than people with dysphagia. So this brings us to the end of this webinar on pharyngeal residue. I hope that you have found the information useful. I'd be happy to take questions, and you can reach me at the email shown on the slide. Thank you for your attention.